Pediatric multiple sclerosis is a chronic, demyelinating disease of the central nervous system, and its incidence in children is rising. Because the central nervous system is still developing, an early onset carries a severe risk of establishing permanent, irreversible neurological deficits early in life. The core pathology is exactly what we see here, a multifactorial attack stripping away the protective myelin sheath surrounding nerve fibers. This destructive process is often triggered by common viral agents, like Epstein-Barr or herpes simplex. This diagram illustrates the underlying mechanism driving the degradation. It operates as a strict 5-stage immunopathological cascade, beginning with the activation of T cells. In the second stage, these activated T cells differentiate into CD4 T cells and begin to rapidly proliferate. Third, the proliferating T cells recruit additional immune components, specifically B cells and monocytes, drawing them into the escalating pathological process. The fourth step is the breach. This cluster of immune cells migrates directly across the blood-brain barrier. Finally, these T cells reactivate within the central nervous system. This targeted reactivation is what actively induces demyelination, stripping the nerves bare. Identifying this cascade in children is exceptionally difficult. The disease rarely presents uniformly, making early detection a task of identifying subtle patterns across diverse symptom sets. To intervene early, clinicians must identify the disease across 4 distinct debut phenotypes. Doing so requires cross-referencing physical symptoms with a matrix of clinical, radiological, and immunological tools. Failing to properly categorize the initial presentation allows the inflammatory cascade to progress unchecked, guaranteeing structural damage to the pediatric brain. These presentations form a 4-quadrant diagnostic framework. The first is the clinically isolated syndrome, or CIS debut, accounting for half of pediatric cases. CIS features a monosymptomatic failure. 35% involve optic nerve neuritis, while 26% present as localized sensory numbness. Diagnosing this quadrant requires pinning down that single isolated neurological deficit and confirming the presence of matching demyelinating lesions via MRI. The second major presentation type accounts for roughly 44% of cases, the polysymptomatic debut. Unlike the isolated failures of CIS, polysymptomatic debuts present as combinations of severe systemic failures. A common presentation is ataxia, a loss of coordination, combined with paraparesis, or partial paralysis of the limbs. The primary example is neuromyelitis optica, defined by simultaneous optic neuropathy, lower limb paraparesis, and pelvic organ dysfunction. Mapped via MRI, 83% exhibit the cerebrospinal form, showing widespread lesions across both the brain and the spinal cord. The presentations in quadrants 1 and 2 are clinically obvious because of their physical symptoms. However, the high variance in those symptoms requires strict mapping to radiological imaging to confirm the underlying autoimmune pathology. The third phenotype appears in patients with 0 primary neurological complaints, the asymptomatic or MRI-only debut. Making up roughly 2% of cases, these are discovered entirely by accident. A child might receive an incidental MRI following a minor head trauma, like a bump on the playground, which reveals the disease. In these cases, a massive discrepancy exists between the complete lack of physical symptoms and the gross demyelinating lesions found on scans. This schematic displays their distribution: periventricular in 99% of cases, the hemispheres in 83%, and the cerebellum in 42%. Clinicians often misattribute these periventricular spots to old perinatal scars, overlooking the presence of active disease. To resolve this, the MRI process requires an intravenous injection of gadolinium contrast. This agent actively differentiates between old tissue and active demyelination. Because the blood-brain barrier is compromised, the contrast leaks into the active lesions, causing them to glow bright white. Structural brain damage often precedes observable clinical symptoms. Incidental MRI findings are a critical early warning system, not an anomaly to be dismissed. The fourth variant is the exact inverse. Here, patients present with classic severe multiple sclerosis symptoms, but their initial MRIs are completely clear. In these 4% of cases, the diagnostic burden shifts entirely away from imaging. Clinicians must turn to auxiliary biochemical instruments. The primary backup tool is cerebrospinal fluid immunology, measuring immunoglobulin G and albumin. Clinicians look for intrathecal IgG synthesis. An elevated IgG to albumin ratio proves central nervous system autoimmune inflammation. This elevation is present in 80% of MS cases, even with a clean MRI. The second auxiliary tool is the measurement of visual evoked potentials. This graph shows how they measure neural processing speed. Clinicians use this data to detect clinically silent lesions that disrupt signal conduction but aren't yet dense enough to be visible on a scan. A clean MRI does not guarantee a healthy brain. Biochemical markers and electrical conduction delays expose the disease well before it manifests structurally. A definitive diagnosis of pediatric multiple sclerosis is a clinical decision, but it relies entirely on building a composite index of these 4 quadrants. This flowchart illustrates the McDonald criteria, the ultimate framework mapping the patient's specific phenotype against MRI contrast activity, IgG synthesis, and evoked potentials. Under this framework, the disease cannot be ruled out simply because an MRI is clean, nor can it be confirmed just because an incidental lesion is found. The clinical and instrumental data must align. Successfully categorizing the specific debut variant allows clinicians to initiate immediate, targeted therapies, utilizing treatments like methylprednisolone pulse therapy or intravenous immunoglobulin. The physiological goal of these treatments is immediate, rapidly clearing the autoimmune inflammation from the central nervous system. Systematically utilizing this diagnostic matrix is the only proven method to halt the continuous subclinical progression of the demyelinating process before it translates into a lifetime of irreversible disability.